It's my sincere pleasure to be here with you this afternoon, and thanks to Carla and the wonderful team in El Paso for all their efforts in bringing this amazing technology to the community. So what I'd like to share with you for the rest of the webinar is bringing an actual mobile stroke unit and actualizing it in your system of care, now beyond the concept into clinical operations. In my disclosure, I'm a founder and consultant for a company which works on pre-hospital stroke care. I've had the pleasure of being the medical director of the UCLA Health Mobile Stroke Unit since 2016. We went into clinical operations as a public-public partnership between the University of California and the UC system and County Board of Supervisors in September of 2017. We serve as a shared regional resource of our county. As such, we take patients to everywhere where EMS would have taken them ordinarily, and we deliver patients to over 15 different hospital and stroke destinations. 2 landmark clinical trials were published last year showing clinical benefit of mobile stroke units in ischemic stroke. The Be Proud trial in Berlin and Best MSU, combining 8 different cities around the world and over 2,000 patients, showing that patients who receive ischemic stroke care in mobile stroke units earlier than they receive it later in the emergency department do considerably better. Not only do we know that these mobile stroke units are clinically effective for patients, but also we've learned from the Best MSU study that they're highly cost effective. And now, given the both clinical benefit and cost and effectiveness data, brings us to real-world clinical application. So today I'd like to focus the rest of my talk on actualizing a mobile stroke unit in your system of care. Beginning with clinical operations, stroke care is a coordinated effort. It does start in the pre-hospital setting with EMS, but then going on to all of the physicians, nurses, and other practitioners in the emergency department, involves neuroradiology, neurology, neurointervention, neurosurgery, neuro-ICU, and finally rehabilitation and family support for the patient for their coordinated care. Mobile stroke units bring the hospital to the patient in the pre-hospital EMS setting. Our clinical operations at the University of California are such. Carla shared her clinical operations. Each program serves a little bit different in terms of their staffing model and so forth, but the general model involves a vascular neurologist in person or by telemedicine. In our program, a firefighter paramedic, a critical care nurse, and a CT technologist. That's the core team for our staffing. We have laboratory capability of performing Chem 8+ and CoaguCheck while in the unit. And we have the imaging capability of performing parenchymal imaging as well as CT angiography. We have the H-slice serotonin scanner, and with this scanner, we're able to perform very, very adequate CT angiograms in order to identify major large vessel occlusions. CT perfusions we haven't performed, as the post-processing only processes one slice through the brain. As such, we have deferred on using CT perfusion in the field. In terms of treatment capability, we're able to treat ischemic stroke with both tenecteplase as well as alteplase. Many of our hospitals, receiving hospitals, are switching to tenecteplase. Some continue to employ alteplase in their system of care, and we choose the thrombolytic or thrombolysis agent based on the recipient hospital. For hemorrhagic stroke, we're able to reverse hemorrhage, or if somebody has a coagulopathy with Kcentra, one could also carry in the future Indexa and Praxibine and other such agents. We also carry blood pressure agents, hydralazine, labetalol, nicardipine, with the goal of reducing blood pressure in the hyperacute setting for hemorrhagic stroke. And other treatments are supportive for neurologic emergencies. These are some images from the field from our clinical operations. As mentioned, we've been operating since September of 2017. And we've grown. We've started in small parts of our community with 1 fire department serving 1 city. And now in alternating geographic sites, 3 different geographic sites in which we rotate, we serve 6 different fire departments in 23 cities across LA County. We did this in an effort as part of a demonstration project to show whether or not this is beneficial for patients. And we were one of the 7 cities in the Best MSU study. We've only had to intubate 1 patient in the field thus far. for instability. And here is how we post-process the CT images looking at large vessel occlusions. We happen to use Rapid AI. There are other providers, of course, and I'll show you just an example. This is a screenshot from my cell phone. Let's say I'm on telemedicine and I'm just able to see the images immediately wherever I am, or whether I finished rounds and I'm commuting to the vehicle and so forth. And here is a screen capture or recording of how we can see these images. And it's remarkable clarity in which we can define whether or not there's a large vessel occlusion. These are the source images that we're going through, but you can also see the reconstruction immediately. And that's incredibly powerful to be able to have these images immediately on the go, identify the large vessel occlusions, and pre-notify the hospitals who are receiving these. We even pre-notify the interventionist by who's on call, so we can expedite patient care, not only in the pre-hospital setting, but also as patients arrive to the hospital. These are the lab equipment that we use. And here's our clinical workflow, very much like El Paso and the other 20-some across the United States. We actually dispatch immediately with the 911 call. Any dispatch either called a stroke or suspicious for stroke. Once we arrive on scene, we evaluate the patients along with the 911 paramedics. And if the patient is suitable for admission, we admit them into our unit, put them on cardiac monitoring, scan, get vascular access, do some laboratory testing. And now with imaging in hand and we have a conclusive diagnosis, we decide the treatment plan, initiate that treatment, stabilize the patient, and then transport the patient to the most accessible site or receiving hospital in accordance with LA County EMS policy and base station directives. Now that we've had our experience with one unit, how do we generalize this so all Los Angelinos, for example, can have access to care? And this applies to your specific environment as well. You have to study within your environment where strokes are happening and where we need to put mobile stroke units in order to offer patients the greatest access to care. This is Los Angeles County, surrounded by Kern County, Ventura County, San Bernardino, and Orange County, as you see here on the map. Los Angeles County is unique in the fact that it's one of the nation's largest counties with over 4,000 square miles, and it has the largest population of any county in the nation with over 10 million residents. Its budget for years has been around $40 billion. Approximately a third of that is dedicated towards health services. The other very special and unique thing about LA County is that Supervisor Hahn's father, Supervisor Kenny Hahn, 50 years ago, we celebrated this in 2019, 50 years ago, he started the paramedic movement in the United States, and this is where the infancy of paramedicine happened. We asked ourselves where to put mobile stroke units in and around our county to benefit the greatest number of citizens. In order to do that, we mapped the incidence of 911 calls, which resulted in the final hospital diagnosis of stroke. As you can see here, a map of our county. What you see, the darker numbers, or sorry, darker shades, imply higher incidence of stroke. So you can see that there's a pocket of higher incidence of stroke in San Fernando Valley, a pocket of higher incidence in Gabriel Valley, and another pocket in and around Inglewood. These are the high incidence zip codes. This is very useful for us in planning. Now that we have the evidence base, we need to bring this into practice and have a fleet of mobile stroke units to cover the entirety of our county. At least that's the dream we have. In order to identify ischemic versus hemorrhagic stroke at the zip code level, this is geospatial mapping of that, showing a very similar pattern of incidence of ischemic and hemorrhagic stroke. However, there are some areas which differ in their intensity. For example, here, you can see that there's in Palos Verdes a high incidence of ischemic stroke, not correlating with a high incidence of hemorrhagic stroke. We wanted to understand whether we need to operate these units on a 24/7 basis or whether just morning time operations would be sufficient for patient care. There was no difference between weekdays and weekends, and we looked at the 12 hours, 7 a.m. to 7 p.m. and 7 p.m. to 7 a.m. Approximately 70% of strokes happened during the daytime hours and approximately another 30% in the nighttime hours. This is the day versus night distribution in our geospatial map, and you can see that the patterns of incidence are quite similar. Next, we looked at neighborhood characteristics. So looking at race ethnicity at the zip code level, we can see here mapped out is the Hispanic Latino ethnicity and race, Asian, and Black or African American. We looked at strokes also by age at the zip code level. So here, less than 1% of stroke happen in patients under the age of 50, approximately 27% between the ages of 50 and 64, and greater than 65% as we expect in the age of 65 and above. Now, correlating these together and why this is important, we can see, for example, patterns. Highlighting here Inglewood with a high presence of African American community, and the stroke heat map showing this high incidence of stroke. And you can see here that also there's a higher impact on younger communities, showing that there's a well-known stroke incidence in younger age in Blacks and African Americans. This is very valuable data. We'll continue to analyze these data, but we also, through the California Health Interview Survey, are able to have access to current smokers, ever diagnosed with diabetes, and currently uninsured. And why this is important, because I firmly believe that these mobile stroke units should be integrated as part of emergency medical systems of care and available to the community who needs it. So next, to talk about EMS integration and policy change needed to make this possible. In terms of integration and in terms of policy and politics, all politics are local and all system processes are local. So one has to study within the environment each system of care and what is unique to their system of care. I'll share with you our system of care and what's unique about it. Los Angeles County has over 414 ALS level fire stations other than the BLS level. What you see here in maroon are all the ALS fire stations, and what you see here in green are the supervisorial lines and distinctions, of which we have 5 county board of supervisors who have been incredibly supportive of us and who provide care to the citizens of Los Angeles within their communities. So the complexity comes in our system of care that we have over 28 different EMS 911 provider services. And all of them have unique dispatch algorithms, and all of them operate within exclusive operating areas. We chose to model a one provider agency model looking at LA County Fire Department, as it serves over 4 million lives, reaches 59 cities in our county, and covers over 3,000 square miles of the county. So looking at a spatial algorithm, what you see here on the map of LA County in blue are the individual 911 calls which resulted in a final hospital diagnosis of stroke, both ischemic and hemorrhagic. What you see here in red are the locations of the comprehensive stroke centers near these calls. We asked the algorithm to position for us in a 10 square mile radius mobile stroke units which overlap in this 10 square mile radius, and the algorithm chose MSU 1 through 5 and outlined here. We realized that there are 2 geographically disparate areas where there's less access to care, and so we asked the algorithm to force in an additional 2 mobile stroke units. Using the 5 mobile stroke units coverage option, mobile stroke units would have access to care for 87% of 911 calls which are dispatched, which result in a final hospital diagnosis of stroke, while the remaining 13% would be served by standard EMS care. Adding the additional 2 units, we can increase that number to above 90% of all 911 calls. Looking at the location of this provider agency, LA County Fire, and here are the fire departments that correlate in a range where we can house these mobile stroke units as an integrated part of EMS care. Next, to talk about funding, and that's the difficult part. Operational costs of mobile stroke units includes the startup costs, the ambulance, scanner, equipment, as well as recurring costs of medication, supplies, and clinical core team lab staffing. The majority of US mobile stroke units and international MSUs have operated with the reliance on philanthropic and special project funds. Several MSU licensing options are available, and different MSUs have taken different approaches, and they have taken a different approach in their pattern of patient transport as well. What we know from public, Medicare approvals is that the Budget Act of 2018 allowed for telehealth coverage and charge billing for MSU physician assessment. Excuse me. We have received tremendous support from the LA County Board of Supervisors, including Supervisor James Hahn. Now, with evidence for both clinical and cost effectiveness demonstrating that MSU care is very favorable, we have to advocate on a major level in the economic, local, and national changes to recognize mobile stroke units as a place of service. This involves both state-level advocacy as well as CMS Medicare-level advocacy. So next, moving on from funding, now to look at quality improvement and research efforts on mobile stroke units. Quality improvement always is a part of our workflow, and that includes EMS dispatcher education, field paramedic education, looking at time metrics for clinical care, and as Carla mentioned, looking at field telecommunications and cellular transfer of CT imaging. We have beautiful imaging that we're able to acquire in the field. However, if we're not able to transfer those images in real time for the physicians to make the clinical decision, that becomes very difficult. Further, we can look at advancing AI algorithms and imaging analysis and improving processes with receiving hospitals, for example, improving pre-notification for neurointerventional and neurosurgical emergencies, as well as identifying workflows which are most effective for patient handoff at the receiving hospitals. In terms of advancing pre-hospital research, the testing of novel neurotherapeutics can happen on the unit. The clinical research looking into hemorrhagic stroke and reversal of coagulopathy, hyperacute treatment with blood pressure control, and so forth, as well as the investigation of novel diagnostic devices and the extension of care in these units to more golden hour emergencies. Another really essential part of mobile stroke unit care and mobile stroke units in your community are education to the paramedics and the trainees and in terms of field education. So here are some images from our field education with residents, fellows, paramedic students, and paramedics who are very interested to learn and advance patient care and advocate for the patients as such. In addition to education of our caregivers, we have to actually outreach the community to educate about the signs and symptoms of stroke so we can accomplish greater things in detecting stroke in patients. And these are some of our community outreach efforts. So I think this gives you a bit of summary about overview of mobile stroke units and how they can be implemented into your system of care, but they have to also be tailored to your system of care, and that the program is involving beyond clinical operations. It's a complex program. However, it is such a worthwhile program to bring to patients now that we have the evidence base. Thank you, and I'm happy to answer any questions at this time.
Great. Thank you, Dr. Nour. We do have some questions, and if you have any questions, please type them into the questions section of the GoToWebinar. The first question is, how do you bill for CT scans in MSU?
So that's a great question. There is no current mechanism for billing on mobile stroke units for CT scans because there's no recognized place of service for mobile stroke units. However, some mobile stroke units programs have taken the option to register their unit as an imaging unit and as such are able to bill for the CT scan. So we're in the process of exploring all of that as well.
Great, thank you. Next question is, have you quantified any cost benefits per patient as a result of sending out the MSU and being able to intervene sooner?
I can answer that question with regards to the best MSU data. That's tallying 7 cities and looking at cost per patient and looking at balancing that cost with the overall healthcare costs and healthcare saving costs. I don't have the exact number that is a per patient dispatch rate. That's going to change depending on your dispatch rate in your own communities.
Great, thank you. Any more questions? I think with that, I would like to thank our presenters and the participants, and we will conclude this webinar. Thank you for your time. Have a great day.
Thank you.